Hi, everybody. I'm Marilyn Drainoni. Can you hear us clearly? I'm going to assume.
Yeah, we can hear you on Zoom.
Excellent. Thank you. Welcome. For those of you who are in the room, the pizza's coming. And we even get a discount because it's late. And for those of you not in the room, hopefully you will be in the room next time because you'll get pizza on time, hopefully. So we, as part of our Center for Implementation Science, I'm the co-director along with my colleague, Alan Walkie, who's over here. And we want to welcome you to this. We haven't done this in this model for maybe 3 years. We did an implementation science training when we first started, then we were doing different things and we decided it's time to come back together, bring the campus together, educate the campus. So we have a 10 series session, which I think Catherine will walk you through the rest of them. 8 series sessions, sorry, thought it was 10. And we'll give you all the dates. But so today we really want to introduce the concept of first of all, who we are, and also the concepts of implementation science. And it's pretty loose, interrupt us, I think, ask questions during, ask questions after. If you have questions in the chat, one of us will try to figure out how to monitor that. And just jump in, unmute yourself and jump in. So just really quickly, I want to walk you through kind of who we are. And what it doesn't work. Wait a minute, the mouse isn't working. Oh, no, that isn't working either.
Maybe press the space bar on the. There you go.
Okay, yay. Okay, so we are the Evans Center for Implementation and Improvement Sciences. We are funded through the Department of Medicine and the CTSI. We're a hub, really a lot for this campus, but really for the whole university around implementation science and really doing methods. So we are really diverse as we introduce ourselves. If you talk to each other, anyone who's worked with us, we're really, really, really diverse in terms of content. Just like Alan's a pulmonologist, I'm really a methods person, but I do a lot of substance use, HIV stewardship. Catherine's an endocrinologist sitting here. Kirsten, who's part of our team, is family medicine and really interested in limited English proficiency. And May is a developmental behavioral pediatrician. Did I get it right? Interested in really trauma-informed care and for families. So we're really diverse. And what brings, and Shana, who's with us, is, I'm Shana, you're little everything, but really very heavily in quantitative methods, but a lot of stewardship and a lot of also diversity, equity, inclusion work. So we are really broad, and what brings us together as a community is really our interest in the translation of research into practice. And also there's a lot of implementation science centers springing up. The difference for our center is we're very much about the safety net. Underserved, that's like really our focus, and everything we do really focuses around this, which is why we sort of sit where we do. So what do? We do a lot of things. We are a team of 10 right now. And what we do is we sort of guide, support innovation in like research design, research methods to move from research to practice. We do a lot of education and consultation with the BU and BMC community on implementation and improvement science. So the way to engage with us, there's lots of ways. I mean, we're always open to conversations, but this seminar monthly and informally between or after that. And then a lot of people have reached out to us for research consultations, whether they're interested in writing a grant, figuring out how to do a project, figuring out how to make maybe a QI project more rigorous, for example, in research, reaching out to us. And there's our website if you want to learn more. So just a little quick picture of who we are. Myself and Alan are the co-directors. Santana is our assistant director extraordinaire. Kayla Jones, who's not here today, she's actually on vacation, is a research specialist with really strong expertise in qualitative methods. She's a applied anthropologist by training. Shana Burrows is one of our fellows. I'm not going to call you a fake fellow. Shana, Kirsten, May, and Catherine, who are here, actually, Shana, Kirsten, and May, who are here, are actually fellows. Catherine and Gabby were fellows with us for 2 years and now are junior faculty on our team. And then Katie Rizzolo, who's also having some health issues, but she's also a new fellow. So we have a 2-year fellowship program that we're open to postdocs and junior faculty. And then lots of people choose to stay on, hopefully get a little support and be part of our larger team. So we're growing. So that's who we are. Now Catherine's going to do the content, most of the content of the day, and I'll jump back in toward the end.
Yes, and I will just ask for our folks on Zoom to please just jump in. I am typically terrible at monitoring the Zoom chat, and I think it's going to be even more challenging not having a computer screen in front of me. So just please like unmute yourself. Welcome. Thank you all for joining us either in person or Zoom. As Mary Lynn mentioned, today is kicking off our 8-part series covering key concepts and methods as it pertains to implementation science, really to give you an overview of the methods that are used, conceptual underpinnings. Today, we'll be discussing principles and key issues in implementation science. But you can see these are our upcoming sessions, the 7 future sessions. We will be meeting on the 2nd Thursday of every month in the 1 to 2 o'clock hour. So in this hour, in this room. So we hope you'll be able to join us. Were we going to record?
Yes.
Great. Okay. So we are going to be recording. Is it in the more?
Yeah, it should be.
I think it's already being recorded.
Yeah, it's already. I must have increased that.
Okay, super. All right, fantastic.
Whoever's
Thank
there
you.
in the Zoom, thank you
Yeah,
for being
thank
very
you.
verbal.
We really appreciate it. Okay, so we will be recording these sessions so that if you have a conflict, if you're not able to make it, they will be recorded, and we are going to be putting them on our website just for, easy access, low barrier learning. All right, so with that, now this is not working. All right, okay. So today we hope by the end of this session that you'll understand some of the challenges of translating research into practice and how implementation science can help address some of the barriers. Recognize key reasons why implementation research is necessary to complement efficacy and effectiveness research in the translational pipeline. Define key terms used in implementation research. Be able to differentiate between implementation, dissemination, and quality improvement, and be able to summarize the 10 key ingredients for an implementation study, which is what we'll close out our talk with. So why does implementation research matter? Well, we know that there is a large and long research to practice gap. It's been estimated and demonstrated that it takes between 17 and 20 years for clinical innovations to reach routine clinical practice. It's been estimated that over half of clinical innovations are never used routinely, and about 80% of medical research dollars don't end up making a public health impact. So we find things that work in research and then we don't use them, unfortunately. And we know that what works in efficacy or effectiveness studies may not work more broadly. So efficacy and effectiveness studies lack consideration about the context in which interventions are applied or application of interventions in different settings and situations. And we know from real life that one size doesn't fit all, and that what works in one setting may not work in another for a variety of reasons. Additionally, applied research has traditionally not been a priority of science. This is changing, but the major goal of implementation science is to speed up the process of translation. And we know that it's not only what you do that matters, but how you do it. And so the strategies used for implementing something, the implementation process, can make all the difference between an intervention's success and failure. So what is implementation science anyway? Well, it's the study of methods and strategies that facilitate the uptake of evidence-based interventions. So it seeks to improve adoption, adaptation, delivery, and sustainment of evidence-based interventions into practice, ultimately to close this research to practice gap. And once we identify effective strategies, they may be generalizable to other situations and settings, and this is the knowledge base that implementation science seeks to create. So moving through the rest of this discussion and moving through the rest of this series, we'll be using a series of examples to illustrate key concepts, to illustrate different methods. And so we'll be grounding this discussion in examples of a couple of different problems. These specific examples were chosen because they either were studies done locally at Boston Medical Center or pertain to investigators here at BU and VMC. So the first is hepatitis C. We know that Hep C is a public health problem. It's estimated that about 4 million people in the United States have hepatitis C. And hepatitis C causes nearly half of chronic liver disease and a large proportion of liver-related cancers. The good news, I think, most of us know this, that effective treatments for hepatitis C exist. And for that reason, clinical practice guidelines do recommend screening people who are at risk. But unfortunately, about 50 to 80% of people with hepatitis C remain undiagnosed because clinicians aren't following clinical practice guidelines. Another example of the problem, and this is a Boston Medical Center local study. So with one of the investigators, two of the investigators in the room. So alcohol withdrawal syndrome in the medical ICU. So severe alcohol withdrawal syndrome is typically treated in the medical ICU with high-dose benzodiazepine therapy. And high-dose benzodiazepine therapy is associated with adverse effects. Over sedation, respiratory depression, prolonged intubation, delirium. There is a potentially comparable course of treatment that has been demonstrated to have efficacy in the treatment of severe alcohol withdrawal, and that is the use of phenobarbital. And so phenobarbital as an alternative treatment was not used at Boston Medical Center, despite having efficacy and the known sort of adverse risks of high-dose benzodiazepine therapy until about 2018, when an implementation study was done here. And lastly, nasal naloxone as a harm reduction strategy. So between 2012 and 2014, the rate of opioid overdoses grew by half in Massachusetts. And we know that nasal naloxone is an important harm reduction tool to reduce opioid overdose death, but it has not historically been widely distributed. We also know that the emergency department is a point of contact for many people who are experiencing opioid use-related health issues, and therefore it can be an important site for the distribution of harm reduction interventions like nasal naloxone. However, it's not typically distributed from emergency departments, and so this is another example of a gap in practice. So what all of these examples have in common, as I mentioned, is that there is a gap moving research findings to clinical practice. Things that we know that work aren't being used. We know that there are problems that are not addressed in efficacy and effectiveness studies and that impede the uptake of evidence-based practices. These include competing demands on clinicians. Primary care doctors are busy. It may be difficult to screen for hepatitis C. Emergency room doctors are also extremely busy. They have a lot of competing demands. It may be difficult to counsel on how to use nasal naloxone and distribute it from the emergency department. There may be a lack of resources, lack of skill or knowledge about an evidence-based practice. For example, lack of knowledge about how to counsel someone on the use of nasal naloxone to reduce opioid overdoses. It may not fit an organization's priorities. And also, importantly, the resources that are put into place during an effectiveness study may be withdrawn at the end of the study, and so practices may not be sustained once those resources are withdrawn. So just before we dive in any further, we wanted to go over a couple of key terms and provide some definitions, just so that we can all be on the same page moving forwards. So efficacy research and effectiveness research, we've talked already a little bit about this, but efficacy research is research that examines the impact of an intervention when delivered under optimal, highly controlled, randomized conditions. This occurs earlier in the clinical translational pipeline, and then we move to effectiveness research, where we're examining the impact of efficacious interventions when delivered in more real-world conditions. And the purpose here is to obtain generalizable results to a particular population. So an evidence-based intervention is an intervention that has been shown to be both efficacious and effective, that has rigorous external clinical evidence from systematic research. These interventions can include programs like a behavioral intervention, procedures, products like medical devices, particular practices, or medications. These are also sometimes called evidence-based practices, and these two terms are often used interchangeably. Now, evidence-informed interventions are a slightly newer concept in implementation science, and these are interventions where there may not be rigorous external efficacy or effectiveness data, but we are borrowing evidence from, say, the use of a program or a practice in another condition or in another setting. And there is enough information or data available to inform the use of a practice in a different setting or population. So this is the assimilation of professional expertise and evidence into practice. All right. So these are some terms that are more specific to implementation science. And this is where I know when I was first learning about implementation science, I got a little hung up, particularly on implementation strategies. And we often discuss implementation strategies. And in fact, we have a whole session that we are going to devote to implementation strategies because it is such a big topic. But intervention components are the core parts of an intervention, the things that must happen in order to retain fidelity to the evidence base. So for example, say you have like a behavioral intervention that in the clinical trials was administered over a certain number of sessions. So you know that a certain number of sessions or a certain dose must be administered. Or you have a program like a motivational interviewing intervention. You know that the interventionists have to have a specific type of training, like training in motivational interviewing in order to deliver that intervention. There are features of the context that can be adapted. Say, for example, the modality maybe in which you deliver an intervention, like remotely versus in person. So you can adapt some components of an intervention to fit context, but the intervention components are the core components that should not be adapted because they are what retains the fidelity to the evidence base. And then implementation strategies are the how-to, or the specific techniques that you're going to use to get an intervention to happen. So for example, if a core component of an intervention or an intervention itself is hand washing, this is how you're going to get people to hand wash their hands. Are you going to put a hand washing station, that's more easily accessible, or provide education? If you're going to be seeking to increase the distribution of nasal naloxone from your emergency department, maybe this is providing education on nasal naloxone use. And then lastly, two more definitions, and we just want to talk briefly about implementation and dissemination. At CIIS, we're really more focused on implementation and implementation research, but we will talk a bit about dissemination. And so we do want to define these for you. So implementation is really the process of integrating an evidence-based intervention into an organization or into a system. And dissemination is more about the intentional process of spreading information and spreading the evidence-based intervention to a more broad defined audience. So it's really more focused on the spread of something versus the integration of something into defined practice settings.
Catherine, can I?
Yeah.
So, and in both cases, right, what's similar is that we're focused on the strategy, the how you do either implement, right? I think that's the linchpin for me.
Yeah,
That makes
exactly.
sense. Yeah.
And then this diagram we thought was helpful in conceptualizing where implementation research fits along the clinical translational pipeline. So our T0 research is our preclinical or our basic science research. And then in T1 research, we're moving research findings into humans. Our T2 research is the research that establishes the evidence base for something. So that's like our efficacy and our effectiveness studies. And then in our T3 research, that's where implementation science and dissemination science sits. That's where we're focused on translating evidence about effectiveness to broader populations, transitioning that evidence into routine clinical practice. We're interested in how people are doing something, how to get them to do it, how to sustain it. That's our implementation and dissemination research. Okay, so building off of Mary Lynn's point, comparing implementation research to traditional clinical research and to dissemination research and to QI. So thinking about implementation research in comparison to traditional clinical research, while it is part of the translational pipeline, it is a bit different. So in implementation research, the aim is really about the how. What is the implementation strategy? How are we going to get something to happen? Is one strategy superior to another strategy when trying to implement a particular practice? Traditional clinical research is really more focused on the what, the intervention. And then I think thinking about the context and the differences in the way these types of research think about context is really important. So implementation research can adapt to context to fit, practices into settings in the best way possible. Whereas in traditional clinical research, we tolerate context and we control for context. Lastly, traditional clinical research is more involved in the discovery of efficacy and effectiveness findings, whereas implementation research is more concerned with focusing on the uptake and the spread of research findings, so not necessarily discovery of new research findings. And the other thing that implementation research can do, because it looks at context, is it can address implementation bottlenecks. It can understand what challenges are existing that prevent implementation and address those in an ongoing way. Ultimately, both have the same overall goal, which is to improve care and care delivery. Okay, so thinking about how implementation research, dissemination research, and quality improvement are the same and different. So as Mary Lynn mentioned, implementation research and dissemination research are both about the systematic study of processes and factors of how we get something to happen. For implementation research, we're really trying to understand how we integrate evidence-based or evidence-informed interventions into specific practice settings. And dissemination research asks, how do we spread it to wider audiences? What are the best methods to share that information and to spread that information? And then quality improvement is a bit different. So all of them, again, have the goal to improve care and improve quality of care, but quality improvement is really more focused on specific local problems. So identifying a specific problem in a specific place and using iterative tests of change to remedy that problem. So it's not necessarily focused on a particular evidence-based intervention. There may be multiple things that you're doing. You're more focused on the problem. And it is also less focused on creating generalizable knowledge than implementation research or dissemination research are. There can be similar methods between implementation science and quality improvement. And in fact, using quality improvement, using iterative tests of change can be an implementation strategy for how you get something to happen. But fundamentally, they are asking different questions and seeking to generate different types of knowledge. So with that, I'm going to turn it back over to Mary Lynn
So I'm here.
to ground the rest of the discussion back in
Projects, yeah. And please jump in. I might actually ask some people to jump in about their projects if we have time at the end. So one of the things I think is why I like implementation research so much is it really is kind of different. And some things are the same. We still are asking questions about how to do something. I love this quote. Carolyn Clancy, who used to be the head of HRQ, always said implementation research is how to make the right thing to do the easy thing to do, which I think is a really interesting way to think about it. How do we make anything in a clinical setting easy for people to do? But I think some features of it that are either different or the same, but I think important. So you have to identify what we call a quality gap. There needs to be a problem, right? And Catherine earlier talked about those 3 projects, which I'm going to go back to, but there's a problem in each one of them. There's a quality gap between what should be and what is. So you have to identify a quality gap and an evidence-based or an evidence-informed intervention that maybe, works to close that gap. And again, that focus on testing strategies. And I think it'll be interesting to hear some people talk about what they mean by strategies, but some of the hows. When Catherine talked about the hand washing idea, right? It's such how do you get people to do it? I get some of my carrot tufts, and lately I've noticed that every time I go for an appointment, I get a survey later. And one of the questions on the survey is about washing your hands. So one of their new strategies seems to be in that system. I didn't know that. I was like, whoa, I'd never been asked that before. We think of things like put a sink outside the patient's room, put up signs, put this, but theirs is like patient satisfaction about, did your doctor wash their hands before they see you? And invariably I say no, because they don't, which is really upsetting to me, actually. They don't do it in outpatient care. It's bad. Anyway, so focusing on the how, and I've been like, oh my God, I don't think of it until I realize they didn't do it. So I think this is a great strategy, actually. We use evidence-based interventions and frameworks. Most of our consults, I'd say, what framework do I pick, right? That's kind of what framework do I pick is kind of the thing. So we really think about how things are implemented. And Implementation science sort of crosses social science, more traditional clinical science boundary, thinking about how things are operationalized, conceptual, theoretically. So we think about like systematic use of frameworks based on our question, our strategies, our design, our outcomes. So we do use a lot of frameworks. I always recommend to people learn like there's 3 categories of frameworks, and we'll do a session on frameworks. I think you're doing it maybe next actually, but there's 3 big categories of frameworks. I always tell people just learn one in each in the beginning, learn one in each and get comfortable with it. And then add 1 a year in each. I mean, that's kind of it. So when you get old like me, you have a lot of frameworks. When you're young like Kirsten, maybe you have 6. But no, but I mean, the point is you just get really comfortable with a couple in the beginning. The other nice thing I think is I love this balancing rigor and relevance. Scientific rigor is really important in implementation science, but it also has to be relevant. So we're not going to let the rigor get in the way of something that's really important for patients in practice. I think another great thing, and I think it's really illustrated by our team, is we're very multidisciplinary. You're always going to work in teams. We work just with all kinds of different people, more quantitatively oriented people, more qualitatively oriented people with different clinical backgrounds. So it's a really nice way it's not the kind of research you do sitting by yourself in the same way, which is really, for me, was very social, a lovely thing. The other thing we really try to do, and it's an important ingredient, is engaging whoever your stakeholders are, whether you're doing a community engaged intervention with patients, with health centers, with physicians, with nurses, whoever it is. If you're doing something outside of the healthcare setting, we focus more on the healthcare setting, like teachers, but engaging the stakeholders, having their buy-in, because I think everyone knows so many things fail if you don't have buy-in, and you can't cram things down people's throats. You just can't. Catherine talked a little bit about this, but the contextual. So it is based on the needs of a system, just like QI. We have a problem in our system, but the goal is the generalizable knowledge. So we like context, unlike more traditional efficacy and effectiveness research, which controls for it. We like the mess of context, but we also want to get generalizable knowledge. We think carefully about culture and community, and those are maybe places we can adapt our interventions. That's really important. And basically that issue of like, what are the core components? What has to be to maintain fidelity, and what adaptations can we have? And that really varies with every intervention. And it's really complex. I always say that implementation science is like not like math at all. 2 + 2 doesn't equal 4 always. As we sat down and tried to figure out the order to do that, it's not like even like statistics, right? You have to learn like some really basics and they follow in order. Implementation science doesn't really follow in order. Pizza's here, so feel free to get up and walk. It really, you move around, like we said, do we do framework second? Do we design second? It kind of doesn't matter. It's very, except for like an intro to it, it is very nonlinear, adaptive, changes a lot. It occurs at all kinds of levels. So we've talked a lot. I think most of us on our team are very interested in changing provider behavior. Maybe 1 or 2 people are interested in also changing patient behavior on our team. You can do it at different levels, but I think our team predominantly is provider focused, maybe a little more patient focused, right? Yeah, which is great. So who are you getting to do something? And the analyses, we mostly using mixed methods, qualitative and quantitative, different kinds of quantitative methods, different kinds of qualitative methods. So they're really multi-component. We also really care both about effectiveness, clinical outcomes, but also the process outcomes, like getting something to happen, those midpoint outcomes. And I'll explain some studies that'll give you that. So as Catherine said, we're kind of going back to these 3 studies because they're studies we know pretty well. They also illustrate different places in the pipeline and different things. So just kind of walk you through a little bit of these 3 studies and how we thought about them. And this is actually a study I did a long time ago at Montefiore in New York, in 3 very large clinics there. So Montefiore is a place with in the Bronx with a really high hepatitis C rate. It was a good place to do this study when we wrote the grant. And but about half of people in general, about half of people don't know about their diagnosis. And that's usually because they don't get tested, screened and tested. So, there was all this new treatment that was coming up when this happened. We have really effective treatment now, but we can't get people to find out they have it, to get treated. Treatment used to be really hard. It's not so hard anymore. It's not overly expensive. So the intervention here that we actually did a sort of cross-sectional sequential intervention in 3 very, very large health centers, like, 150,000 patients, each kind of health centers. The first part of it is our implementation strategy and intervention was, the first intervention was a high-risk behavior questionnaire. So finding out somehow from patients about the set of 9 or 10 risk factors that would make them eligible, with then the idea that providers would test them. That was the first one. And then the second one, after about, it was sort of a crossover study. And so after that, we tried a second model, which was basically screening people in a birth cohort at highest risk, just saying, screen everybody. How will we do? So we use 3 implementation strategies, 3 primary implementation strategies, a lot of education and training of providers, a lot of environmental providers through that engagement process with them said, we really need environmental reminders. So we made like pocket cards about the intervention in multiple languages to give to providers to remind them to do it. We had posters in all the exam rooms. We had buttons. We had all kinds of like swag as well, but a lot of reminders. And then projects, actually, there were 2 pieces of this. One was having clinical champions at each site. And then second was having staff, both clinical staff and research staff at each site. So I had research staff in New York who would go and pick up things, just be available. And then we had clinicians on the team who were connected to these health centers as well, who weren't really our champions, but they could be in there for education and training. So those were our strategies, if that makes sense. There's these interventions and there's these strategies. So how we were going to get these 2, we use the same strategies for both interventions, because the research question here was, 1, can this work in general? Can we do it? And which one of these strategies is better? Does that make sense? So, and I'm not going to actually go through all what we did, because we're going to talk about this throughout the next 8 months, but our framework here was the Proctor model for implementation research. So it's a kind of model that was really a process model, really walked through a process, made sense. And you'll have another session where we talk about models and why. And then what were we looking at? We were actually looking at both some clinical outcomes and some implementation outcomes. Our clinical outcome was the positivity rate. So what % of people tested positive? And then and this is all pretty quantitative. These were, hundreds of thousands of patients. So it was all quantitative work, which is sort of outside of my comfort zone, but it was fun. And then increased rates of screening and testing. So did people use, these 2 interventions, and did we see an increase? So that's sort of one model, completely different, and we will go through this more and more. The phenobarb study, and if I forget anything, Alan, you can help me here, was a local study. It was done here in our ICU, in our MICU. And again, as Catherine said, what was happening was the docs in the MICU were noticing really the negative effects of benzodiazepines on patients, and they felt like maybe potentially on staff as well. And there was another intervention that we thought was comparable, not necessarily better or worse, but comparable at least, and non-inferior, essentially, is the kind of evaluation we did. But it wasn't being used. And so the strategies here to get that intervention to practice were really different, actually, than what we did at Montefiore. There was engagement. There's always engagement. You'll always hear about how engagement happens. But in this case, it was a lot of Nick Bosch, who's one of our critical care docs, really led this with one of our CIIS fellows, spent a lot of time meeting with staff, buy-in, training, really working with NICU staff. Nurses were really important here, probably way more important than physicians. Aren't they always? And also putting in an EMR order set. So we use like an electronic, which is an implementation strategy, change the EMR, and a real engagement strategy. I was surprised, I had forgotten we used the same model. Oh, well. So, but and then the outcomes were different. So we were doing intent to treat analysis, non-inferiority, looking at change in certain patient outcomes before and after on the intervention, basically compare pre-post on mechanical ventilation rates. We also looked at length of stay, restraint, because those are the things that were happening with the benzos. That was the quantitative component. The qualitative component was really important to the study, clinician perceptions and changes in the workflow process. And then our goal eventually would, it was scaled and generalized. This really became the pathway in our MICUs here at BMC. I've gotten a lot of good press on this, but I think it's really been important. So it's another way. This was a really successful, I'd say the Hep C one was a moderately successful. Partly, I think when Catherine said something earlier, we were really there reminding, and then we kind of disappeared. The other one really just became practice. The last thing, and this was sort of happening pre the huge, a lot of my work is in the opioid space, so I know the space well, but it really was happening before the current crisis, and BMC was seeing the crisis before anyone else. And so we were seeing a lot of people with overdose coming in the emergency room, or feeling among some of our sort of key advocates, clinician advocates in the emergency room, that this was important. So they wanted to figure out like who was at risk. So we did this big analysis to figure out who was at risk of overdose, which was an interesting thing to do because it's not really clear who's at risk. But what we found out is only 7% of the people who came to the ED with an overdose or who they felt were at risk based on some criteria from the EMR were actually given a kit to go, a naloxone kit to go. So it's like, this should really be a good place, as Catherine said, to do this. So, the interventions really care. Give somebody Narcan. I mean, it's really, really simple. It was so hard to implement. So what they tried, basically, they tried these things. They tried to make Narcan available 24 hours through a bunch of different mechanisms in the ED. They had a standing order because it used to be that Narcan, now you can walk into CVS and ask for your Narcan, but this wasn't like that then. So they had a standing order for any staff person to go pull this and prescribe it. And they created a policy we'll talk later about this, but you create policy at this level, whatever. But that's what they did. And they thought this will work. And we used a different framework, which is called the CIIS framework. This was very formative, qualitative work. And you'll hear why, because what happened was they did all these things. We studied it for a year. We looked at the data. I pulled the data again. Absolutely no change. I actually think it went down a tiny bit. I think we went from like, almost 8% to like 7%. So it wasn't a lot, but we had a lot of patients. So it was enough that basically we weren't seeing it. All these strategies, all this effort, all this real passion just wasn't happening. So they actually came to me and said, will you study this? Tell us why it didn't change. So it's a very different so it made sense to use what we call the CIIS framework because it looks at evidence, context, facilitation, like what happened. So, and basically what we learned, we did only qualitative work around this because we had our number when number was bad and it wasn't going to change. So like, what does this mean? Who's at risk for an overdose, right? They're like nurses and doctors, like, you know how many patients we see here? What does this even mean? You didn't define the target groups. It's all over the place. It just doesn't make sense. You're here in the emergency department. People get dumped in our emergency department with nobody. If you've ever had Narcan, you don't want it right away again because you don't feel too good. So patients weren't really open. So they didn't really think about this, whereas they maybe should have targeted the pediatric ED where people come with a parent, for example. No attention at all to implementation strategies. This was this idea that if we make a standing order and we make a policy from on high, and this ED knows, I've talked to them about this a million times, so there's no secrets here. They weren't happy, but this is what it was. They thought it would work, but they never trained staff. They did it sort of randomly. You catch somebody in the hall, you catch a fellow, that doesn't work. And then in July, everybody changes. So wasn't nothing in the EMR. There were just no attention to the facilitation of the strategies. And the idea was strong champion belief, passion. I mean, the most passion I've ever seen for anything. It's not enough. It's necessary, but it's not sufficient. So then they made modifications, but it's a different challenge. We think of the Mickey one is really implementation success. This one implementation challenge, and the other one just a really interesting design activity. So these are 3 studies. These are general examples of what is an implementation study versus some other kind of study. So, you're often identifying strategies to encourage change, better health services. And any of our fellows can tell you what they're using for their strategies. Identify strategies for integration of evidence into even policy and programs. Some people are really interested in sort of implementation science at more that policy change level. You might be studying fidelity. You might have an intervention. I think your interventions will really be right for fidelity, right? Because we're really looking at doing a much more intensive intervention. And what is the fidelity of that? Like, are the things done as they're supposed to be, basically? Studying how you could do CBPR, community-based research in really diverse settings. I think if the last 3 years or 3.5 years have taught us anything, is the importance of community and community engagement for all the negative things. I think that's a positive. So understanding that, we talk a lot about it at this hospital and at this institution. I'm not sure we study how to do it well yet. Intervention adaptations by population and setting. Catherine talked earlier about what are the things you really have to do, but what are the things you can adapt and how do you do it? And there's really methods of studying that. And then identifying that, maybe what works I have a big implementation study now that I'm doing. Alan's part of it and Shane is part of it too, at BI, Leahy, and Deaconess. And I anticipate that potentially where we're looking at improving prescribing via telehealth and risk assessment. But I anticipate that it's possible that what works here might not work in our health center in Quincy where we're doing it, or what works here might not work at BI or at the Leahy system. And, the BI, we're also working with their Chelsea Health Center. What works in their flagship hospital with their Russian-speaking patients may not work at all. We're doing this in 5 languages in Chelsea with a very different population. So studying that as well is another example. I guess last but not least, before we open it up, is the 10 key ingredients. A lot of times people come to us and they want to write an implementation science study. Everyone wants to write a grant, and people have really caught on to this, and it's great. So these are the things, and these are all available to you too, that really have to be included. So you really need to identify a gap between what the evidence-based care is, like screening for hepatitis C and testing, and what's usual care. So you need to show a problem. Right? Any research, you need to show a problem, but this is really a gap between usual care, or I want to say standard of care, usual care, and evidence-based care or standard of care. The background. So you need to tell people about that evidence-based background. Like, what is that evidence-based treatment, or that evidence-informed treatment, and really give an argument for why that's important. Theoretical or conceptual framework, really important, and why. I can't tell you how many grants Alan and I see where people say, I'm going to use this framework, and it's never mentioned again in the grant. It has to all tie together, the framework, why you're using it, the outcomes, why you're measuring them. It's like you make a puzzle, essentially, that ends. Stakeholders. What are the stakeholder priorities? We can't cram things down people's throats. So you need to have that in your grant and how you're going to engage in it. So the setting and the provider's readiness to you engage with them. Are they ready to do this? Because no one will fund an implementation study if there's not some evidence or clarity that you've engaged with people up front and they're willing to try this, because that's the biggest recipe for failure. What are the strategies? What are you considering? And that's an interesting dance, right? Because you're going to be like, well, I'm going to meet with the stakeholder. I'm going to spend time with them so the strategies could change. So we always say, put in some strategies, suggest some strategies, and know they're flexible. Implementation science has to be really flexible. If you're not flexible, you don't want to be an implementation scientist. They want to know that the team, and this is the multidisciplinary nature, is really important. If I'm going to do a study in our family medicine department, I'm going to have Kirsten as part of that study. if I'm gonna do a study in pulmonary, I want Alan or somebody, and also if I'm gonna do a very heavily quantitative thing, I need a quant person. If I'm gonna do a qual thing, I need a qual person or all of the above. So that's really important, and the setting and the processes. So it's usually a bigger team, but it's usually very workable. Feasibility of the methods, of course, like in any grant. What is your measurement, your analysis plan? How do your outcomes link to your conceptual framework, to your aims, et cetera? And then is there support within the setting? You know, they want to know, if I tried to do that work in the emergency room, but there was no support in the emergency room or in the larger hospital system, that would have been a bust. So with that said, our little summary to sum up this is there's a lot of barriers, right? When you try to apply evidence-based interventions in the real world setting, and implementation science in some ways is really a space to try to help address those barriers and really break it down. And also really help us understand how evidence can be applied in the real world. It's very real world based. And as Catherine said, try to take that 17 to 20-year process and cut it down. Implementation science is an interesting space. There are centers that are very implementation science theoretical, that they spend a lot of time thinking about theory and design. We are a very practical center, and both have validity, but our focus is really how can we do this? Implementation research is great with context. We like to adapt for it and evaluate strategies by context as well. But that's really what makes it different than traditional clinical research. It's really focused on effectiveness and really controlling for context. I always think of this when I used to teach this class, we would talk about how, like, if you're doing an efficacy study of motivational interviewing for people with HIV and substance use, an efficacy study, you wouldn't enroll people who were maybe homeless or something that had something that would make them just more difficult because it's not controlled. In an effectiveness study, you would enroll them, but you would control for them in your analysis. Implementation study, it's like take all comers and figure it out. So it's just a really different way of thinking about it. Again, we think we are more implementation focused, most of us, but it's not saying we don't do some dissemination research, but we're really interested in integrating evidence-based interventions into practice, either for patients or providers. And the dissemination is really the scalability, the uptake. What are the implementation strategies to spread? It just sort of seems the people who've been part of our center are more on the I side than the D side. And most things aren't either all I or all D. There's usually something in the middle. Again, quality improvement, really important. The MICU study actually started as a quality improvement project. And if you read that paper, it says this quote, but we said, we don't want to just do a quality improvement project. We want to identify an evidence-based intervention with rigorous methods so we can make it generalizable. I think that was a big difference. And we always are encouraging, particularly trainees here, to like get out of the QI space, or at least take the QI space, but make it generalizable. And then those features that we talked about, quality gap, systematic use of evidence-based interventions and framework, this multidisciplinary approach, and like the complex contexts are a good thing. So I think that's us, and open it to questions. I see something in chat, but I have no idea how to monitor this chat. And the pizza's here, so eat, please. There's 10 pizzas over there.
Oh, it just said yes. Nothing in this chat.
Oh, I saw everything in the chat.
That's someone saying yes.
People have questions, stop. Go get your pizza first, and then. And I think if anyone wanted to even talk about any projects, to give examples or.
Oh, someone wrote.
Okay, I can't figure out how to monitor the chat. There's no computer screen.
I know.
Hang on, it's a little hard without a screen.
It's okay. I can do it for you, Dr. Drainoni. Dan Merrigan asked, thanks for the great presentation. Will the slides be shared?
Yes, right?
Yeah, so we recorded this presentation and we'll be sharing the slides with everyone.
Thanks, Dan. Other questions, thoughts?
Intrigued, I've heard the term like evidence-informed interventions before, and coming from a discipline that perhaps is a little bit less solid in terms of really strong effectiveness data. I'm curious if there's any guidance anywhere on like the bar, like what, or like, not a specific answer, but like something that you're looking for, where something would sort of meet the threshold of like, okay, this could be an
I
evidence-informed.
don't think there's any guidance on, because the bar is really moved. When I started doing this kind of work, there was no such thing as evidence informed. It was evidence-based, Cochrane review, must be that. Then I think a bunch of things happen. One of them is we have a lot of really evidence-informed things that work, but there may not be a Cochrane review. And, Cochrane review, it's not the be all and end all, especially when the recent one just came out that masks don't work or may not work. That one made me very nervous yesterday. But so I think that it's not a clear bar. And so I think it's really morphed into, we can do this because there's some evidence that it works. I think, Catherine, what you said, that there's some practice, et cetera. So there isn't a clear bar.
Like the phenobarbital study
Yeah.
is evidence informed. There wasn't great evidence that phenobarbital was as good as or better than benzos. And so that's why, the outcome is sort of non-inferiority effectiveness outcome.
Yeah.
And so the amount of evidence that's supporting your intervention might help guide what type of, we'll discuss this in future lectures as well, what type of study design you select on the continuum of sort of hybrid implementation effectiveness studies. So if it's evidence informed and there's not a huge amount of efficacy, effectiveness evidence, then you maybe want to study the effectiveness a little more and the implementation a little less. Whereas if it's hugely evidence-based and everyone knows it works and there's like the biggest meta-analysis ever, then you just want to implement it. You know it's gonna work, and so you don't have to look at effectiveness as much.
So that's, I think, where you make your choices, if that makes sense. But there's not a clear line between what's informed and, Someone else had a question.
Yeah, first off, thank you. This is fairly informative. I'd love to hear more about the work going on with improving patient behavior or changing patient behavior, because I'm not a clinician at all. And so, but I'm vaguely aware of some of the levers to change clinician and provider behavior, but I'm not as aware of the things that you can do to change patient behavior or what, you study in CIIS.
I think it varies so much. You do a lot of thinking about patient behavior change. I'm not sure who else does.
So I think some of the questions we can ask are similar to questions about provider behavior when it comes to patient behavior. So I am an endocrinologist, but really a diabetologist. And so when it comes to managing diabetes, a lot of that is about, the behaviors of an individual with diabetes. And so we can ask questions around like, why do people with diabetes, use certain treatments more than other treatments, and we can apply implementation strategies to try and encourage use of certain evidence-based treatments. I think we can ask similar questions about like study designs. We can look at effectiveness and implementation, both with, sort of like strategies that are directed at patients and patient behavior, as we can with clinicians and clinician behavior. I'm not sure if that answers your question.
Yeah, the other thing I think about a lot is think about some of the work that people have done to change, whether it's diet or smoking, money, offering money, different kinds of incentives. So I think a lot of patient behavior change focuses maybe more on incentives than on understanding the reasons why, because maybe those basic reasons are so hard to change. So I don't know what we're specifically doing as much around that, but those are the kinds of questions.
And I think also you can look at the list of implementation strategies, and for example, coaching is one that's like an implementation strategy geared towards changing individual level behavior. There's also some interesting implementation science on this in areas of substance use where there are not evidence-based treatments like Suboxone or methadone. So like stimulant use disorder is one, there's no FDA approved treatments for it. And so all the evidence that currently exists is really around incentives. So like giving people graded incentives for how long they go with abstinence and sort of different types of in-clinic types of treatments you can do. So I think it is like a space that we've thought a lot more about how to change provider behavior, mostly because it's really, really hard to change provider behavior. It is hard to change individual behavior, but so much of provider behavior is your how you were brought up in the medical system and the culture around you. So I do think has been less a focus of implementation science.
Yeah, and one of the things that Kirsten raises, the contingency management call for substitutes, is we did a study here, like 10 years ago, where we were part of a larger trial for people with HIV and substance use disorders. And we gave them money, cash, and they could make a fair amount of money, like $1,100 for doing certain things around both their HIV care and their substance use care. And because all the literature showed that in substance use this worked really well. It failed miserably on the HIV side. For all 10 sites in the study across the country, whether we were in California, Alabama, Texas, it was like somehow it works much better in substance use than in the HIV space. Around some of the same behaviors, around adherence, even around addiction treatment when you also have that going on. So it was very, I'm not sure we know why, but it didn't work as well in the clinical space. So it's so interesting because think about all the other clinical things like giving people money, like to lose weight, to eat better. I don't know, but why was it in this case? And I don't think we know the exact mechanisms of why it didn't work. So I don't know if that's, I think we're moving more, but I don't know what we're specifically doing right now around that space.
I think that's patient focused.
Yeah, the smoking thing you're doing.
A little bit about, we have a project where we're trying to improve the documentation of smoking history in the medical record, which is terrible, but which also drives all these automatic best practice alerts in the medical records. For example, patients, identifying patients who are eligible to have lung cancer screening is done through their smoking history, but if the smoking history is wrong, then all the best practice alerts that alert clinicians say, hey, can you order lung cancer screening, CAT scan for this patient are wrong, and it just all causes a mess. So we're doing patient-focused intervention where essentially patients are getting either MyChart alerts or text messages that ask them to just enter their history themselves, like how much you're smoking per day now, how many years you've been smoking, and that is more accurate. We're finding and actually getting and gets people to fill it out more, but using different behavioral economics, theory-driven strategies for what type of messaging the patient responds to best, and what time of day, and all these things. It's all involved there. So that is a patient-centered intervention and a patient-centered study that is, sort of implementation science as well, behavioral economics. You can apply it to the clinician.
We have a second study now, it's prescribing strategy that we're doing where we're co-designing materials with patients. I mean, we think it's mostly provider behavior because they're prescribing, but it's patient behavior because when you come in, you make all this effort to come here, miss work, you kind of want something in the end, right? You want that antibiotic in the end. And so we are trying to work to at least change patient behavior through some education that they desire. It just, I think, so I'm definitely more focused on the provider side, but I think some of our colleagues have focused more on the patient side. Just feels like it's the get it into practice field,
And I think you'll find that in a lot of implementation science, there's multi-level
Yes.
interventions, because if you intervene just at the provider level, you're not going to be effective, or just at the patient level. And so and we'll talk about that a little bit in the implementation models, about how to think about those multi-level drivers of behavior and outcomes.
I hope that's helpful.
Yeah, thank you.
Anything else? Our team's available, our emails are available, right, Santana, and reach out, and we're really happy to engage with people throughout the year. I don't think there's anything else in the chat. Anyone else on the phone need us, want us? have a question?
There will be in person next time, yes. So the next one is October 12th and we'll be meeting here from 1 to 2 the same time.
And
And
pizza will be on time, hopefully.
hopefully the pizza will be on time and we'll be focusing on theories and frameworks.
Right, if we go back and forth. Next, you're leaving.